So, hello everyone. Our topic today is the cholangioscopy. I know to many of us until recently this was a very vague and dark area, and we really want to know what it's all about and how we can benefit from this new technique. So let's start. Why actually do you need cholangioscopy? Isn't ERCP good enough? I mean, we do get good results. We have a cannulation rate in expert hands of about more than 95%, stone extraction in over 85%. We achieve drainage in over 95% of cases. So why all this hassle and this expensive devices? So let's, I think, move back a little bit to maybe 30 or 40 years ago. We had the barium enema, which was a good exam that shows you the colon, but then we could go inside the colon and we see these very nice images of the colon itself. So with the same analogy, you can say that currently we have this good contrast image of the bile ducts and pancreatic ducts, but this is what we can achieve with a cholangioscopy. So it's a huge difference. And why is it a huge difference? First of all, you can actually visualize the pathology itself. You can take biopsies. For cases with difficult stones, you can actually do lithotripsy under endoscopic vision. And as you can see, you can selectively access specific ducts, which is something that is usually a bit difficult and time-consuming with the ERCP. So yes, it does add a lot to the ERCP procedure, and we will see so in the following slides. Now, how did it start? In 1976, actually, there was this accidental cholangioscopy where they went in with an endoscope, gastroscope, through a choledochoduodenostomy. In the early 80s, there were the first developed mother and baby scope systems. So these require two operators to handle the endoscopes. In the mid-80s, they made these ultra-slim gastroscopes to achieve direct cholangioscopy. In 2007, there was the first single-operator fiber optic mother and baby system, which was called the Spyglass Legacy. And finally, in 2014 or 2015, there was launched the digital Spyglass system, which is a single-operator system. So let's see the main difference. So this is the direct cholangioscopy. You can see here that there is a slim endoscope. It's like a gastroscope that goes directly inside the bile ducts. Now, of course, this has, you can assess from this image clearly that there is a main disadvantage is the excessive looping that will happen, first of all, here in the stomach, and secondly, here in the duodenum. So this looping is usually a big problem that makes it difficult to proceed with the procedure. Some people have devised techniques to overcome this, for example, by using an anchoring balloon. So a balloon that they put here and they pass the endoscope over this balloon to reach inside the bile duct. But still, it is quite a difficult technique. So, so these are the mother and baby scope systems. It's a basic ERCP duodenoscope through which the small slim endoscope passes inside the bile duct or the pancreatic duct. Now, the first ones were the dual operator system. These are the ones that we hear about from our perhaps older colleagues and they tell us that they were very fragile. I think in every endoscopy unit, you'll find one or two broken endoscopes because these were really very fragile and very difficult to handle. And then there is the single operator, like the one that we will be using today, where a single operator handles both the cholangioscope and the main duodenoscope itself. So this is the main system that is now available as a single operator now, which is the Spyglass DS system. It comes in this compact system that you add over the tower that you're using. It's attached to the endoscope, and it comes with these very useful catheters like a Dormia basket and a snare to get a migrated stent, the biopsy faucet, which is called the Spy Bite, and the probes, of course, for the laser or the electrohydraulic lithotripsy to break the stones. So if we do a rapid comparison between those, so this is the mother and baby dual operator. This is the direct cholangioscopy, which is the ultra-thin gastroscope, and this is the latest Spyglass. So of course, here the main disadvantage is that you need two operators. The good advantage of the mother and baby is that they have a relatively slim outer diameter, which is 3.3 millimeters. So this is as thick as a 10 French stent. So you can imagine it passes easily into the bile duct, even if it's not really dilated. Now, the direct cholangioscopy is actually quite big. It's about 6 millimeter in diameter. So this will impede passage, I think, beyond the hilum. So it's hard to go in intrahepatic ducts. So the challenges with the older mother and baby scopes are the scope fragility, as I said, the need for 2 operators, and a small working channel. The direct cholangioscopy, of course, you need a wide sphincterotomy and you need a wide CBD to accommodate this large endoscope. The access and stability, of course, are a bit difficult due to duodenal looping and looping in the stomach. Now, the single with the spyglass, I think the only remaining thing that we need to address is the working channel is still very small. It's about 1.3 millimeter. So this makes the biopsy size a bit small, and sometimes it's not enough to assess the pathology. So this is an example of a patient I had. This was a patient was 28-year-old male. He came in December 2016 with obstructive jaundice. He had an ERCP which showed a hilar stricture involving the common hepatic duct and the right and left hepatic ducts. So he underwent extensive investigations, including CT, EUS, tumor markers, IgG4, oral non-revealing. And he was told, look, you have primary sclerosing cholangitis. We don't have anything to do right now, so you just have to keep exchanging these stents until eventually a transplant will be needed for you. So of course, this was a pretty bad situation. And what made it worse, that over 2 years, he needed about 10 ERCPs. And with the last ERCPs, they failed to cannulate the left duct completely. And this actually led to atrophy of the left hepatic lobe in the last CT. So we decided to do a cholangioscopy. And this is an example of how cholangioscopy can actually make a huge difference in the management of a patient. So this is the cholangioscopic image now inside the bile duct. So this is the normal image, this whitish lining of the bile duct. And then when we approach the stricture, we were surprised to find that it's actually not an inflammatory stricture. It appears like a papillary formation. So there's a growth at this area. So we managed to move also through this papillary growth to reach with the cholangioscope into the intrahepatic bile ducts. Now, of course, first of all, we thought that one of those is the right and left hepatic ducts. But actually, when you get to pass a guide wire into one of the ducts, you understand that these are actually the intrahepatic, or this is all the right ductal system. And this is why by ERCP, it was impossible to go into the left hepatic duct. So the actual orifice of the left hepatic duct was found more proximally below, in midst of the stricture itself. And of course, with some maneuvering of the cholangioscope, we could eventually target the left hepatic duct. So this is the image here of the cholangioscope, and you can see that we selectively could target eventually the left hepatic duct that previously failed by ERCP. A cholangiogram showed these markedly dilated ducts with these ectatic ducts from the recurrent cholangitis. And the achievement, of course, that we were able to drain both ducts. And I think the bigger achievement in this patient was that we took a pathology biopsy, and it revealed benign biliary papillomatosis. So the whole management of this patient changed. This patient was directed to do a surgery. He had a resection of this segment and direct anastomosis of the bile ducts, and he did very well. So he's not anymore a primary sclerosing cholangitis patient. He doesn't need a liver transplant, and really this patient's life has been saved. So how good is the spinal gap cholangioscopy? How effective is it? Now, ERCP alone, we know that it's terrible in differentiating the type of the stricture. However good you are, how experienced you are. If we look at all these images together, and I ask any one of you, tell me which is cholangiocarcinoma, which is IgG4, which is primary sclerosing cholangitis, I think you won't be able to tell the difference easily. So And this was a study that confirmed this actually in assessing patients with IgG4 exposure cholangitis in about 48 ERCPs. And they sent the images to 17 physicians blinded to the diagnosis. And they found that the sensitivity for the diagnosis of IgG4 cholangitis based on the endoscopic, on the ERCP image alone was only 45% with a very low inter-observer agreement. And several cases with IgG4 were misdiagnosed as PSC or cancer, of course, based on this alone. So no, it's not good enough. So how good is the SPY bite biopsy in comparison to our older techniques like the intrabiliary biopsy or the brush cytology? I'm sure all of you know the brush cytology. Some may not be acquainted with this with the intraductal biopsy, but there are dedicated biopsies that you can just throw inside and blindly take biopsies from the area of the stricture. And then finally, there is the SPY bite biopsy. So this was one comparative study that showed that there was a huge difference in the sensitivity between both techniques and the SPY bite, as well as the accuracy. So yes, obviously, the SPY bite does add significant impact in the area of obtaining a histopathological diagnosis. But is it perfect? I mean, is it good enough so we don't need to do anything more right now? I think no, we still didn't reach this point. This was a systematic review that revealed that the sensitivity of the biopsies were about 60% only. Yes, the specificity is approaching 100% or 98%, but the sensitivity is a bit low at about 60%. And this is probably because of the small size of the biopsy forceps. Now, the visual assessment does have a role, and you can see here that of course, the criteria on it are still not standardized, and we're still learning every day how to differentiate a malignant and a benign stricture. But you can see the hallmark of the malignant strictures is the presence of these neovascular elements, neovascularization, and the papillary projection inside the bile duct in comparison to a benign stricture. Now, in another systematic review, they also assessed the visual assessment, and they actually found that the visual assessment was highly sensitive and specific in actually differentiating benign and malignant tumors. The sensitivity was still about 70% with the biopsy. But of course, in practical life, it's very difficult to take a decision on a patient based on solely the opinion or the vision of the endoscopist. We need some improvement on the pathological aspect and the biopsies. And I think recently there has been released a newer biopsy forceps that has a larger cup size, and hopefully this will get better results. So moving into a practical point of view, does the cholangioscopy actually change things in our patients? So this was a very, very important study. It was done on patients who were all destined for surgery. The majority were cholangiocarcinomas, some were IPMN, and a few were PSC. So they decided in all these patients that we will do a cholangioscopy or a pancreatoscopy before the surgery to map the region and see the extent of the tumors. So, of course, the technical success was 100% in all of the patients. Now, this is the strange and alarming number. So the endoscopic mapping changed the surgical plan in a third of the patient, 34%. And actually 22%, they avoided surgery completely. 8% had less extensive surgery and 3% had more extensive surgery. So the question is, should we do a cholangioscopy to every patient who's destined to a pancreatic biliary surgery? I think according to this study, yes, but of course we have to consider the other factors such as the economy and the patient tolerance, the procedure, and so on. But yes, it seems to have a great impact. Now, the other major use of the spyglass is used for difficult stones. So now back to the same question, how good are we at stone extraction? Because we feel at the point that we can do everything in ERCP and we usually handle stones very well. But this is from the real-life census by the British Society of Gastroenterology. They found that only 69% of the GI units achieved the standard of 80% stone clearance. In the Netherlands, a similar audit and about 8,000 patients found that the overall procedure success to extract the stones was only 85%. So you have about 15% of patients that you cannot adequately treat by standard ERCP techniques alone. And why does this happen? Mainly because of stone-related factors like, for example, the stone size, stones above strictures, and patient-related factors, for example, like a post-surgical anatomy, the presence of a duodenal diverticulum, and so on. But I would say that the majority of the problem will be the stones that are big, more than 50 millimeter, or those above a stricture where you cannot extract the stone. Now, what we used to do for a while is that we said in patients who are old, we can just keep a stent and leave it in place. We don't have to extract the stones. So, but actually, you find that this technique is associated with significant morbidity and significant biliary-associated mortality. So it's not a good technique. So in an old patient, just to tell him put a stent and leave him and let him go home. So Spyglass offers two main methods to break the stones, maybe the laser lithotripsy or the hydraulic lithotripsy, who have similar efficacy in several studies. This is perhaps one of the largest studies where they found, and they compared EHL with laser lithotripsy. The mean time was a bit longer with EHL, so 74 comparison to 50 minutes. But overall, the ducts were cleared in 96% of patients. And remember, these are patients who are already very difficult stones. So these are the 15% that we couldn't extract. And the majority, 77%, were cleared in one session only. So I would think that currently, when we have stones, we manage them by the conventional techniques like endoscopic sphincterotomy, balloon extraction, balloon sphincteroplasty, I think has now saved us a lot of procedures. And in the vast majority, you will be able to extract the stones. If you don't, I think the next step would be cholangioscopy with EHL or laser lithotripsy. Finally, you can resort to the more difficult procedure like the transhepatic lithotripsy. And finally, surgery. Now, how serious is cholangioscopy? Because I know many endoscopists are afraid to go into this. They think it's a bit a dangerous procedure. So this is a real-life single-center experience from about 206 patients with 250 Spyglass exams. And you find the overall complication rate was 13.2%. So initially, when you look at this, you think it's a pretty high percentage. But there's a very important point. Cholangitis composed 8% of these, so it's the majority of the adverse events. They initially did not administer antibiotics, where they had a 12.8% of cholangitis. But when they did start giving routine pre-interventional antibiotics, this fell to 1% only of cholangitis. Other complications like pancreatitis, bleeding, and perforation are really extremely rare, especially if in experienced hands. So in conclusion, the Spyglass DS system, it does show landmark technological advancements like the ease of use, the image quality, the accessories that are available to use with them. More than 95% of cases with difficult stones, we're able to clear them with the system. The visual assessment and the SpyBite, they do provide adequate assessment of stricture, but there is still room for improvement in this area. And actually, cholangioscopy does alter the management in a significant proportion of patients. We await room for development from the industry in regarding standardization of diagnostic criteria, the biopsy capabilities, methods to analyze the samples better, and of course things like MBI and chrome endoscopy will be a good addition. Thank you. I think now we will be shifting to a live case that my colleague Dr. Mustafa Ibrahim will be doing it. I will be joining him, and we have Nuran here who will give us a brief about this case right now.
So we have a female patient. Sorry, we have a female patient, 58 years old. She presented with obstructive jaundice. Her labs finding were total bilirubin of 7.8 and direct bilirubin of 6.7. Ultrasound was done showing distal CBD stone with dilated CBD and intrahepatic biliary radicals. Previous ERCP was done showing distal CBD stricture, and the plastic stent was inserted. The patient is for assessment of the stricture by Spyglass. So we will now shift to the live case. أنا شفت عليه.
Okay. Good afternoon, everyone. So it's really my great pleasure to do this live case today with my friend Professor Hany Shehab. So this is the first, I think, this is the first live case in our area during the COVID-19 period. So as you can see, we are dressed differently. So all of us, I'm here in the room. I will be supervised by Hany in 5 seconds. And I have also Salma and Ramadan helping me, and I have our X-ray technician Amr, and Dr. Dina is controlling us from outside, doing the anesthesia for the patient. So as you have heard the history of the patient had, I did for her ERCP 2 weeks ago, where she had been diagnosed with obstructive jaundice due to a stricture. And this structure, you will see, if you can see in the mixer room, if you can broadcast the X-ray image, you have a still image now of the X-ray. So in the X-ray, you can see now I have already removed the stent, and you have seen there is a structure very distal to the papilla, where I can pass by the guide wire. I tried last time to pass by anything, by a bigger stent or a biodilator or a balloon dilatation. I failed. And this is why when we thought, me and Hany, that this is a very good indication to understand the nature of this stricture. So already Hany is here. So I think this is the first time we work together in this. We are friends for more than 15 years now, and this is the first time to work together. So before I'm ready for the dilation. So during my dilatation, I will ask Hany to present a little bit the SPY scope. So we have the SPY on for you. And this is the SPY scope. So please, Hany, I will dilate during Hany is explaining the scope itself. You can zoom, please, on his hand. So what I did, that I removed the stent, I cannulated the common bile duct, and now I'm dilating by a 15 millimeter CRE balloon from Boston Scientific. And we will start dilation while Hany will explain everything about the scope.
Okay, can you see now well the system? Zoom على system. Okay, so this is the spyglass system. You can see it's similar to a standard endoscope that we use. So we have the up and down movements and the right and left movements. It also comes with a very handy lock that can lock your position. Okay, and it has an irrigation and working channel. Now, as I said in the presentation, so it's a very slim endoscope. It's 3.3 millimeter in diameter, so it's as thick as a 10 French stent. Now, once Dr. Mustafa will be finished, you'll see how we'll attach this to the main endoscope, and we'll insert this through the working channel of the duodenoscope.
So it's very important, as you can see, that now we need to dilate the papilla. We do a sphincteroplasty. I already previously did, I already previously did 2 weeks ago a very small sphincterotomy, but it's very important to do the sphincteroplasty just before the insertion now of the spyroscope itself. So normally I will wait for 1 minute for this dilatation. So what do you think, Hany, about this? It's a small stone, or it's a, because I tried to remove it by a balloon. I cannot dilate this area. So what do you think about this?
I really from the cholangiographic image, it's really hard to tell. Yes, there seems to be like something rounded below. But you said when you passed like a Dormia bus or something, it wasn't mobile with you, right?
No.
So
and even when I tried,
like
even with a balloon, with an extraction balloon, it always stopped before without any movement. So now I will start deflating my CRE balloon.
So do you usually do a balloon dilatation with every cholangioscopy? Do you need to do that?
This is a very important question. I think it's not mandatory, but personally, when I do this, I prefer for many reasons. So I'm here, but not only dilating for the cholangioscopy, but also I'm dilating because if this is a big stone, we will remove it afterwards. So I need to have a very good access. Number one, for the insertion of the spy scope, as well as after that for the extraction if this is a stone. So you can see now I'm dilating. I will remove.
So as I said earlier, of course, there's still no standardization for this technique. You'll find many different schools. I personally usually don't prefer doing a dilatation because it will make the vision inside maybe a bit more difficult with the bleeding. But of course, it depends on how you feel about it during the procedure.
Yeah. So now I'm exchanging with the guide wire X-ray, please. So we still have the guide wire in place. This rounded lesion is still there. However, the contrast already had been already vanished from the common bile duct. So now I have the guide wire. So I will ask our cameraman to zoom on my hand while Hany is starting fixing for me the spy scope.
Now the setup is pretty simple. It's a simple click in. So we just click in the spyglass into the system, and it automatically turns on. And then we attach this to the handle. تحت شوية. تحت شوية.
Okay, so you can see it now. It's fixed to the system itself, and we have the knobs, the same like the knobs we have it in the scope for the transmission of the movement to the tip of the spy itself. So it's very important. So now I will start exchanging, same as with any stent or anything. So I will go. So I have the guide wire in place. I have no problem to push very fast, but the only thing that you should be very careful when you reach the elevator. And this is the where previously you can really destroy the spy itself. So the second version now is 100% better than the previous version, but it's very important to take care while you are taking the scope out. It's okay. Yes, so we have the spy now here. I will go inside the common bile duct. And then we will shift to the spy image now. Maya. On, X-ray on. ما تغيرش مكانك. Okay. So we will clean. I think I'm out again.
We're out.
Yes.
Yeah.
So this is very important. So I will go to my endoscopic view again. So I will adjust my position like this. And then I will go a little bit inside.
So of course you can go inside without a wire. It is possible, but using a wire usually makes it easier. Okay, so it's not a routine thing. It's not a necessity, but it usually makes the procedure easier, especially if you have a distal pathology, what can make the entry a bit more difficult.
So I entered, and now I will shift to the spy image. Irrigation, please. And now I will start adjust. You can see irrigation.
So irrigation is essential throughout the cholangioscopy procedure. And perhaps it's one of the reasons why there is a little bit higher risk of cholangitis, because you're injecting under pressure. So I think there is something at about, yes.
I will pull back few millimeter my spy scope. Yes, there is something here. Huh? I will try to have a better image. Yes, it's here.
So this is our guide wire, and you can see
You think we can remove the guide wire? What do you think? No. No, I'm asking you, what do you think? We should remove the guide wire and
I think when you remove it, it makes it a bit easier for you to maneuver inside.
Okay, I will go back to the endoscopic view, where I will make sure that I'm in the good position first of all, because you can see now. Yes, I have been a little bit. This is very important technical question. Sometimes when you start concentrating only on an X-ray on the endoscope and the spy image, you are excreted. So I will aspirate all of this.
Yes, it's very common, and this it's one of the things that we'd like to work on with the industry, how to stabilize the position once you're inside. But it's very frequent that this happens, that you fall out once you're inside. It's helpful if you can always have the endoscopic image with the spyglass image at the same time. This is not available on all systems.
Yes, I have the guide wire in place. X-ray, please. Okay, so we have still the guide wire in place. I will introduce again my spy scope. X-ray. So I'm almost just in front of this lesion. So I will ask now I will stay like in this, and I will ask to change to the spy image. On X-ray on. So I'm a little bit again backward. This is like this is better. And now we will manipulate irrigation.
We are usually used to that.
Yes, it's here.
Yeah.
Okay, stop irrigation. What do you think?
I think it looks like.
For me, it's not a stone, huh? What do you think? There is
I think we need more
irrigation more.
I think it is a stone problem, Mustafa.
Yeah, there.
I think it is. Yeah.
Could you remove the guide wire very fast,
okay.
Please?
So guide wire out.
Okay. And now irrigation more. Yeah, it's a stone, huh?
It's a stone.
Yeah, you can see, but I think
it's an odd-looking stone.
Yeah,
but
it's very odd, huh? And you have a lot of also of tissue hyperplasia.
Yes, the inflammation around it. Yeah.
I think it's a long-standing stone, which I have personally I didn't see this already. I'm out. So okay, I will shift to the endoscopic view again. But I think now this is. You think we need to take any biopsies, Hany, from this tissue around it?
I think yes, it's not a bad idea to. I mean, once you're inside already and you're with the cholangioscope,
we take some biopsies. Huh?
Yeah, just take some biopsies. Yeah.
What I will do now, I will try what exactly Hany said in his presentation. I have cannulated without the guide wire. Now, X-ray image, please. So I have cannulated now without the guide wire, and I will shift to the spy image. So this is another, as Hany said. So you don't need every time to yes, irrigation.
Irrigation, please.
Irrigation. Yes, you can see it's very good picture. Huh? So we have a very nice stone. I will pull back few millimeter back like this. Even you have a better image now. What I will do now, I will take just biopsy from this this lesion on this inflammatory area on the right side. Do you think it's important, or we should remove this stone?
I think we should just I think remove the stone, and maybe afterwards take the biopsies. Or would you
Okay.
like to?
Yes. Okay.
Okay.
So we will shift now to, you can see the image again. So this is, I think it's a very good image where you see a very strange looking stone with some inflammatory bile duct mucosa just distal to it. So we will put now a guide wire, and we will exchange trying to remove this stone first. So a very important question. You will answer all the questions in a couple of minutes, Hany, but what do you think about how if we cannot manage to remove this stone now with a normal basket? What do you think about so you do EHL or you do mechanical lithotripsy? The $1 million question.
So yeah, I'm actually a bit worried about this this stone, because as you see, it is a radio opaque stone, and this means probably this is a very hard stone. So this is not the stone that you will grasp with the basket and it will break with you. So
X-ray?
I would be worried about an impaction of the stone if we don't have a really wide.
So this is also important, just important point before just I need to continue. So we have cannulated now again, we have put the guide wire through the spioscope, which is to change it to a new to another ERCP. So if you can see the X-ray image now, X-ray on. So we have cannulated through the spioscope, which is now what I will do. I will remove back the spioscope, leaving the guide wire in place to start extraction of the balloon. Okay, so please continue.
So yeah, I think this stone, it's probably a very hard stone, as it's a radio opaque stone. So I would be a little bit worried about it while extracting it, or careful. We have to be really sure that we have a wide sphincterotomy or sphincteroplasty. It's not very big, but it's probably very hard. So the question is, if it doesn't get out normally, what would I do? A mechanical lithotripsy or a spyglass directed lithotripsy, EHL. Of course, I think we don't have enough direct head-to-head studies so far, but by simple logic, if you can do the procedure while you can have the stone visualized in front of you, then this is probably the safer and more effective procedure. Probably, I'm saying. I'm not taking into account the costs and so on and time consumption.
Yeah, I think the same. So if we can do anything under vision, it's better. But again,
better.
The cost of an EHL device versus a simple basket is not the same. But if I have it on everyday availability, I would love to do all my stones by EHL.
Sure.
So I will now. Okay, what you do, Hany? We put a basket, or we try one with an extraction balloon.
So tell me the balloon dilatation. How big was it? The balloon?
I dilated 15 millimeters.
15 millimeters.
Yeah.
So it's a good dilatation.
Yeah.
I think it's you can proceed with a basket.
With a basket. Yes, we will have a basket, and also we have ready here also a mechanical lithotripsy if needed. But I will start by a very I would say simple trial of basket removal.
Basket.
Okay,
so we remove the wire and you.
What I do normally, it's you know that there is only 1 or 2 small baskets in the market that they are over the wire, but I keep the wire just for a few seconds first to guide my direction. So this is always what I have learned from the VR, that I guide my direction of the basket itself, having the wire in position, and then when I'm inside, I will remove it immediately. X-ray. Okay, so now I'm just behind. There is no need more for the guide wire. You can tell me, okay, but this is you will go out in a lot of times. I know, but I would love every time just to make sure that I'm inside. Okay, X-ray on. Open the basket. So I open normally the basket above. You can see now the basket is just around the stone. I will try to manipulate a little bit.
Yeah, now it's coming nicely inside the basket, I think. Ah, slipping.
Okay, I will go again a little bit inside. Normally in your daily practice, Hany, you remove it while the basket is open or closed?
Usually open. You don't really need to close the basket. Because actually, usually when you try to close it, the stone slips out from the basket. Of course, it's a very common problem that you find the stone like in this position, probably laid in like a small pocket at the end of the CBD. So every time you pass the basket, it passes tangentially to it, and you can't really get it in the middle of the basket.
I'm trying to a little bit.
So as you can see, he's trying to get a more vertical direction of his basket to get it more in line with the stone.
Could you close a little bit like this? Open. So I tried to very عشان اخش تاني. So it's not an easy one. Okay, open. X-ray.
Sometimes it helps when you go a bit in a longer position with the endoscope, going more in the direction of the Yes. So as you can see here, what Mustafa did is he went a bit deeper with the endoscope. So he wants the endoscope to be immediately below the papilla.
Ready?
And as I said, as you can see, it's a hard stone. Usually with the more commonly seen stone that when you pass a basket, you find fragments coming out and it gets fragmented with every pass. But you see here that it's not even getting fragmented.
And also, I think due to this being there for a long period, as when we have seen with the SPY, that it's due to this also inflammation and hyperplasia of the CB of the common bile duct mucosa.
Yeah.
So this is why it's a little bit, I think, touching the mucosa and a little bit stick to the mucosa. This is why it's not very easy, and this is why last time without the SPY, I failed even to understand what افتحي, to understand what is this. Push my scope a little bit. انت فاتحه اخرك خالص؟ اقفلي كده، جربي بالراحه. قفلتي؟ قافله على حاجه؟ Okay, we have something inside the basket.
Slipped again.
Yeah, but it's.
Would you like to try an extraction balloon, perhaps? Now that we did,
we can shift to.
A good
we can try with the.
Yeah,
we can try with the balloon.
So usually, how big do you do the sphinctoplasty? Is it standard for you, a 15, or does it change?
No, I can, and sometimes I even go higher to 18 or sometimes even 20. So 15 to 18, this is my standard range, depending mainly on the dilatation of the common bile duct itself. So, and also, yeah, if there is no diverticulum near to the papilla. So, but one of the important aspects for me is the common bile duct is dilated well. So if you have a very dilated common bile duct, I'm not afraid of dilating up to 80 maybe. Okay, so I will pass over the stone like this balloon. So we inflate the balloon, and then we pull back. We pull back. So normally maybe this is not all my friends here, but I have learned to do it like this. So I will fix the balloon by my hands. I will make the scope very near, so maximum up with the scope, and then on screen on. While fixing the balloon, I will do down, and then I will start torquing the scope as much as I can. So this is to try to be as maximum in the direction. Okay, so you have the balloon already deflated.
It's a very hard stone.
Yeah.
Very, very hard stone.
So I think it needs just a lot of time with the basket to catch it, huh?
Yeah.
Yeah. So I need the basket again. It's very hard and very stick to the common bile duct. So I think the plan, we will try for a few more minutes with the basket, and then if we don't succeed to do this, I think the second step will be doing this EHL for this patient. So I have another technical problem now with the PPE, which is sometimes when you work like this, you have a little bit of fog inside your goggles. X-ray. So this is again working in the COVID area. COVID period is not very easy. Huh?
Yeah, especially these long procedures.
I'm starting to. I will push a little bit my. انت فاتحه خالص ها. You can see Hany, every time it comes only from one side. حاولي تقفلي كده بالراحه. ماشي 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 ماشي.
No.
اتزحلقت ها. I will go again. On X-ray on. افتحي. I think there is also now, but yeah, this is a bigger stone, but there is the spy basket, huh? Did you have use it, Hany?
No, I didn't get a chance to use it, the spy basket, but it looks, from what I saw, it looks like a useful tool. I'm not sure about its size, how big of stones it can get. I think it's probably mainly designed for these small intrahepatic stones that you can't really reach them. But I haven't tried it yet.
I think this is, in this stone it's very big for it, but again, one of the two new tools of the spy, the accessories, the spy basket and the spy snare, where you can really use for a very smaller lesion. I will try. I have, I think, part of it now. I will push my. I will ask Salma to close very slowly. Okay, so slip. So I think I will continue doing this. It may take time. On.
Does pushing the endoscope inside make a difference? Does it, going more, below? It's a different technique that sometimes is a bit more useful.
The problem you see here now, when I'm near to the stand itself, to the stone itself, the basket start to collapse. I will try to pull like this. See. Okay, close. Okay, I will continue, Hany, but I think for the time frame, I have a lot of questions to be answered. So Hany will join in the mixer room to continue answering the question. and I will continue trying to remove this stone. So for the mixer room, please shift to the questions where Hany will come to answer.
So a lot of questions. I'll try to answer most of them as quickly as possible. So we had a question about, can we remove the papillomatosis in the bile duct like a polypectomy instead of surgery? Most of the cases of biliary papillomatosis are usually extensive, so they're not like a single small pedunculated polyp. And I don't think that removing them with a polypectomy would be possible. Plus, the current available snare with the spyglass is not actually connected to an electrosurgical device. So it's just a snare so that you will be able to grasp, for example, a migrated stone, but it doesn't actually cut using an electrosurgical device. Now, there was a question, do you think every biliary stricture needs a cholangioscopy? That's a very good question from Dr. Mohsen from Bangladesh. No, not every stricture needs a cholangioscopy. At least with the currently available data so far, we don't think so. For example, if you have a distal stricture and the patient has on a CT has a large pancreatic head mass compressing the bile duct, and EUS shows an invasive pancreatic adenocarcinoma, then you don't really need to do, unless you are considering perhaps the extent of the surgery. Will the cholangioscopy make a difference in making it bigger or a smaller surgery? But no, not all of them, only when you really cannot determine with the basic criteria. Laser or EHL, which do I prefer? My experience is mainly with usually with EHL, because for availability, it's more available here. According to the results of studies, laser takes less time, so it's probably easier to use. Okay, because these are usually very lengthy procedures. They take usually at least an hour and a half to do. What should be the least diameter of CBD to perform a cholangioscopy? There isn't a minimum diameter, because as I said, the cholangioscope is 3.3 millimeter in diameter, and you have your normal CBD is usually up to this size. So whatever the size of the bile duct, you can do it. There's no problem. Now, there's a question about, do you prefer use a guide wire or not with the spy scope? It makes it easier if your position is not stable. But so especially if you have a distal pathology and you want to maneuver mainly in the distal CBD, this is the most difficult with the cholangioscope, because this is where your endoscope falls easily and the spyglass falls easily. So usually if it's a distal stricture like the one that Mustafa was working on here, I usually prefer to have a guide wire to aid in the insertion. When it's an easier, more proximal stricture in the hilum, usually don't need a guide wire. But of course, it's helpful to have it if you feel it's difficult, then just use a guide wire to aid the insertion. To intubate easily, you need to stay close to the papilla as possible. Yeah, I'm not sure if this is a comment or question, but yes, of course, it's very important to stay close to the papilla with the main duodenoscope to maintain the stability. Because what happens is once you push the cholangioscope, it pushes the endoscope, the duodenoscope itself back away from the papilla, and this is where you can lose the position and fall completely. What is the risk of bile duct injury or perforation if laser or EHL is used? Now, the risk from the studies published is extremely low. Yes, I know that when you think of it logically, you're using a laser directed that can hit the CBD wall, that it can cause perforation, but actually the risk, as I showed in one of the studies, is less than 0.5%. So the actual risk is pretty low. Now, there's a question from Dr. Sadiq Mustafi saying, so why did we do the cholangioscopy first in this? Why start with in this case in particular? So this case, as we said earlier, it was diagnosed in a previous ERCP as a stricture. It didn't show that there actually was a stone. So this is why we started by doing the cholangioscopy to see what the cause of the obstruction, and now it's evident that it's a stone. How many times shall we try to extract a stone with a basket? There is no specific number, not even in the guidelines. There is a specific number of trials with the stone. It's something left to the operator discretion. If you feel that you have a chance that you're doing something, then continue. If you feel that it's futile, you're doing the same thing over and over, then you have to stop at some time. Someone is asking a question about there's an increased risk of future cholangiocarcinoma in those who have a generous sphincterotomy. I don't think that there is sufficient data to support this statement, and I think even if that there is this minimal increased risk, I think it doesn't outweigh the benefit of having an adequate sphincterotomy to actually properly treat this patient at this point of time. Someone was asking maybe if we have a larger basket, maybe may trap the stone more easily. Actually, no. When you have a larger basket, it actually gets more difficult to catch these smaller stones. So I don't think this would be a solution. There's a question of why don't we use a spy basket? Because a spy basket is very small. It wouldn't get this stone. I think it will probably get stones less than 1 centimeter, about maybe half a centimeter. It's very small. It's mainly designed for the small intrahepatic stones, but not for these large hard stones. Question about the difference in complication rates between later lithotripsy and EHL. As far as I know, there hasn't been any significant difference in the complication rates or in the efficacy. They're both as effective and they're both safe. The only difference, significant difference, is the difference in the time. So lithotripsy, in the study that I put here, it took about 50 minutes in comparison to about 74 minutes with EHL. So that's about an additional 24 minutes per procedure. Cold snare polypectomy in CBD, I don't know. I haven't tried it. Theoretically, yes, but no data so far on this. But I'm pretty sure it can be done, but I'm not sure. Now, a good question. For a distal stricture, do you do a cholangioscopy or an EUS? And also for the proximal ones. Look, in general, a distal stricture will probably be well evaluated by EUS, and a proximal one will probably be better evaluated by a cholangioscope. But it's not a blanket statement. There are sometimes when you have a distal stricture and the EUS doesn't reveal a cause, or it does reveal perhaps a thickened CBD, but it doesn't actually get a good pathology specimen. So you do need sometimes a cholangioscope and a distal stricture. But in general, yes, if I have a patient with a distal stricture, the first thing I would probably tell him do an EUS first. Okay. So I think we will go back now to the endoscopy room. Maybe we'll catch the rest of the questions later. I think Mustafa will be doing some spy bite biopsies. Okay.
لا ها ماشي يا باشا. Okay. Okay, so I will just give you the feedback what happened, that I didn't succeed to remove the stone. I think the stone, because I think the stone is stick to the wall of the CBD. So what I will do now, I will go with the I go again with the spy scope, X-ray. So I will go again with the spy scope inside the common bile duct like this. X-ray, please. Okay. So I will just come out a little bit of torque. Yes. Tanya. I will go inside again like this. I will pull my. So the idea now is to take a biopsy. I will take a spy bite. I take a small biopsy to this tissue, which is distal to the stone, which is a little bit. I think this is, we need to prove that this is inflammatory, because the stone itself. X-ray. So I think I heard, Hany, that you have 40 questions more, huh? So I will not take a lot of time. I will just take a biopsy, as you said, because I didn't succeed by any means to mobile the stone, because it's very X-ray. Okay, we have here, so we can shift to the spy image now. I tried with the spy itself, isn't even to push it. So you can see here, I will pull a few millimeters back. You can see down here. So the stone is there, but there is a lot of tissue irrigate a little bit. there's a lot of tissue. This is why I would love to take a very small biopsy, just irrigate. You see? So it's impacted in the mucosa. So what I will do, I will take biopsy. You can see this here. It's a very beautiful image. So this is why I think it's impossible. I need to remove this, because it's you have the tissue hyperplasia around the stone itself. You can see here. So what I will do, I will take just a spy bite, a biopsy. Yeah, we have the biopsy out. I will take just one from here. I'm out of the scope. I will go again. I will take. Okay, just this was the plan, Hany. I think you can continue your questions, but
Okay.
this is what I would like to show to the people, that this is not the everyday stone. Huh? So this is why sometimes it's very important that to understand. So now we have a very difficult stone which is impacted in the common bile duct. We will take biopsies, and I think we will send all of you even what we have, the results of this pathology. Okay, so I will go inside like this again. So I think now we can run shift to the questions again to Dr. Hany. Okay, X-ray. انا هطلع بالسباي وطلعي لي بس.
So back to some questions here. Is it really a single operator exam, or is it better to use an assistant in certain cases? It is actually a single operator if you consider like a single physician or endoscopist. So if you have a good nurse that is acquainted with the cholangioscope, you can do it alone. Practically, what we have been doing in our experience is that so far, usually when you do a cholangioscopy, you do it like me with someone else, like another endoscopist. But this is because we're still gaining the experience on the visualization and of this new technique. But there are days that I do the cholangioscopy alone. You don't need it, but you need, of course, a very good dedicated nurse that knows what she's doing with this. There's a question, did you give the patient an antibiotic? Yes, of course, we do routinely give third generation cephalosporin before and actually after the procedure too. This is routine, as I showed, it dramatically reduces the risk of cholangitis, which is pretty high if you don't use it. So question from Morocco, are there some precautions to take into consideration when you perform EHL to avoid complications? Well, yeah, the risk of complications with EHL, I think the main risk is having cholangitis. So first of all, of course, definitely have antibiotic prophylaxis. Secondly, the thing is you should, these are very, very lengthy procedures, and you are inside with the cholangioscope and you are persistently irrigating. The thing is that you tend to do when you forget, you keep irrigating a lot. And this, I think, increases the risk of cholangitis. So you have to reduce the use of the irrigation as much as possible. You don't have to always have this crystal clear vision of what you're seeing, especially because you're not assessing a stricture. So reduce the irrigation as much as possible, give the antibiotics, try to not stay too much in the procedure. So it's not a bad idea if you just break a stone in some procedure. You passed an hour, then you can stop and then bring the patient after a few days. But when you increase the time, it probably increases the risk of complication in this patient. Question, is there any role of the spyglass in benign biliary stricture? Well, of course, the main indication is to confirm that it's a benign biliary stricture, which is our main issue. So yes, it's extremely important if you have a stricture to confirm that it's benign with cholangioscopy. If you are meaning, for example, a post-cholecystectomy stricture, that you are confident that it's a benign stricture, you don't really need to assess it by cholangioscope, but it's sometimes useful to help you direct the guide wire. Sometimes if you have a benign stricture, but the CBD is angulated, and your wire keeps going into a wrong direction, the cholangioscope helps you direct the wire. There's a very nice paper published on the use of the spyglass in patients with a living donor related liver transplantation, who had failed ERCPs due to this extreme angulation of the bile ducts in the living transplants. So they do help in directing the guide wire, especially in those post-operative cases. There's a question: can we do CRE sphincteroplasty in this patient? This is what we did. This at the beginning of the procedure, we did a sphincteroplasty up to 15 millimeter, and I don't think with the size of this CVD we can go further. You're going to push for a perforation. Question: would Habib probe help in extracting impacted stone with an inflammatory stricture? No, I don't think so. The only indication so far is the use in strictures to increase the patency of the stents of when you put in a malignant stricture. But to my knowledge, it has not been used in removing stones in an inflammatory stricture. For this patient, is surgery indicated after failure of ERCP? No, I think we still have a lot of techniques that we can use. Maybe we couldn't use today due to some availability or due to the time constraints, but this patient still has a chance to undergo a mechanical lithotripsy. He has a chance to undergo a laser or EHL lithotripsy. Maybe if these fail, then we can go to surgery after that. Question about extraction of cystic duct stones, is it possible? Yes, actually, we had one of those cases in our unit where a patient, we found, we thought it was a stricture, and then we found a stone, it was in the cystic duct. And actually, we could go deep inside the cystic duct with the cholangioscope, and we could break the stone and we could extract it. So yes, it's doable. Now the question will be, would you still proceed with a cholecystectomy after it or not? We did. This is what we did in our patients, but at least we removed the stone that was impacted the cystic duct. Any role of irrigation of the CBD using antibiotic at the end of procedure? Yes, this is this question from Mahmoud Bouda. Strange that you asked this question, because this is a question. This was a technique that used to be used it's like an old school technique. Some of our older professors, they used to think that this is good and they could use it, but I think now we know that injecting antibiotics introductory could actually itself cause some cholangitis and could cause some permanent problems like sclerosis. So I wouldn't do this routinely. And as far as I know, it hasn't been described in spyglass cholangioscopy that you inject introductorily the antibiotic. Question about the use Iswell for breaking large CBD stones. No, we have a problem in our country with the availability of Iswell. I know it has been very effective in especially pancreatic stones, because these are extremely hard stones to break, but we don't have experience with Iswell actually here. So I think we'll have to wrap it up now. Thank you all. it was a difficult case, and I'm sure you can stay in contact with us for any further questions. You can send them onto our to the website of Roya, and we'll get back to you as soon as we can.
Thank you everyone for joining us today. Thank you, Dr. Hany and Dr. Mustafa, and we will see you all in another webinar. Thank you.